Thank you for coming. I am Dr. Joseph Chablis. I'm the Medical Director for Metabolic and Bariatric Surgery at Venice Regional Bayfront Health. We're going to do a seminar presentation on metabolic and bariatric surgery. The way that this will be structured is we will present a PowerPoint, which will last about a half an hour, and then we'll have plenty of time to take questions from the audience. And my manager is here. She'll take insurance questions, and we also have our program coordinator from the hospital who can also talk to you about the hospitalization. So thank you and welcome, and we'll go ahead and get started. So at Venice Regional Bayfront Health, we are a duly accredited center of excellence for metabolic and bariatric surgery. One of our designations is through the Surgical Review Corporation. The other is through the Metabolic Bariatric Surgery Accreditation Quality Improvement Project, which is a joint venture between the American College of Surgeons and our society, the American Society for Metabolic and Bariatric Surgery. So when we talk about overweight, we use this term BMI, body mass index. It's a ratio of one's weight to one's height, and the normal BMI is 25. Obesity classes start at BMI of 30, and they go by fives. So class 1 obesity is between 30 and 35 BMI, class 2 is between 35 and 40, and class 3 is greater than 40. In the United States, about 1/3 of US adults, which is 80 million people, are considered obese, and it's about 1/3 of men and 1/3 of females. So how many people in the United States undergo bariatric surgery? Well, we currently do about 200,000 bariatric surgeries a year, and that number has been pretty constant for a few years. Currently in the United States, there are about 16 million people who qualify for surgery, and that's the BMI over 40 number. So basically what it means is that we're really penetrating this epidemic problem at about 1% or less in terms of the number of people who need surgery. So who qualifies for surgery? Well, we define obesity for surgery as a BMI more than 40 or a BMI more than 35 with at least one high-risk medical problem, and we call those comorbidities. And comorbidities that we're familiar with can be type 2 diabetes, high blood pressure, sleep apnea, lipid problems, fatty liver disease, or arthritis, and there are many others. We also want to see that people are psychologically stable, that they're knowledgeable about surgery and its potential outcomes. That's what the seminar is about. That they're motivated to be successful, and that they have medical problems that do not preclude their likely survival surgery. Well, what does that statement mean? What it means is that we take a very comprehensive approach to our patients. We work our patients up very thoroughly. We make sure that if they have specific medical problems, that we have the appropriate specialists that are involved. And so, for example, if someone has a heart problem or any heart history, we'll have them see a cardiologist before. If they have a lung problem or we're concerned about their lungs, we'll involve lung specialists. And so we like to get our patients to quit nicotine prior to surgery and for life. We either have them moderate or abstain from alcohol. So we have a very, very comprehensive approach to getting our patients ready, and we take that very seriously. So the next thing I want to clarify, because you see a lot of this in our seminar materials that are in front of you as we're talking this over, is this term metabolic surgery. So what does this mean, metabolic surgery? Metabolic surgery is the idea that we use these anatomic changes that we make to the anatomy of the patient as an intentional way to treat a disease directly, like diabetes. So what we're talking about is the direct effects of these operations anatomically that have an effect on medical problems, but not related specifically and directly from weight loss. What does all that mean? I'll make it simple. What it means is that if a patient, for example, that has diabetes has surgery, that it's not that the patient has surgery, loses 100 pounds, and their diabetes goes away. We know that this idea of metabolic surgery is that when the patient has surgery, often, before maybe they even leave the hospital, their diabetes is already in what we call remission, okay, and their blood sugars are normal. That's not an effect that is because people have lost weight. So that's what we mean by metabolic surgery. Now, the mechanisms are very complicated, and we're going to get into a little bit of them, but they're about changes that happen in the gut, important hormones, things that relate to bile acids and the way that they're metabolized in the body. But mostly the easy way to think about it is we're changing the metabolism of the patient. And we're doing this, and often those benefits are happening even before the weight loss happens. Okay? So what are the options as far as surgery is concerned? Well, there are 4 US and worldwide frontline surgeries that we do. And they're all done laparoscopically. And for those of you that don't know what laparoscopic surgery is, that's minimally invasive surgery, making small incisions instead of making big cuts to do what we want to do for the patient. So those 4 operations are, and we'll go over each one in detail, adjustable gastric banding, sleeve gastrectomy, Roux-en-Y gastric bypass, and then biliopancreatic diversion with duodenal switch. And we'll call that surgery the DS or the switch because it's shorter. So we're going to start by reviewing the laparoscopic adjustable gastric band. So this depiction you see in front of you, this illustration, shows a band just placed below where the esophagus and the stomach meet. And the idea here is that we can create a small reservoir or compartment. Now, the band is the only operation I'm going to tell you about that's not a metabolic surgery. This is an operation where we just try to create a small reservoir and give the patient portion control. And the idea here is with portion control comes a limitation in calorie intake, and hopefully that can lead to weight loss and improvement in medical problems. Now, the band has really been declining in popularity over about the last decade. It peaked in about 2005. The reason why there are still people who are interested in the band and surgeons who still offer the band is because that people have a perception that the band is a lot safer in terms of some of the more high-risk problems that can occur after surgery. And that's very well true, and I'm going to show you some data that supports that. The other reason that people like the band is that for the most part, a lot of bands are done in what we call an outpatient setting, in that patients can come to the hospital and have the surgery and often go home the same day or just after an overnight stay. And so patients like that idea. People also like the idea that with a band in the office setting, we can make what we call adjustments to it, where we can just with a little bit of prep in the skin, without a lot of times even an anesthetic, local anesthetic, we can access what's called the port and add fluid, and we can tighten and loosen the band accordingly in the office. So patients really like that idea. Now, the disadvantage of the band, and the reason it's become less popular over about the last decade, is really 3 things. Number 1, as far as weight loss data is concerned, and I'll show you some of that, the band is really not a great operation for weight loss. We like to see that people lose about half of their excess weight from the procedure that we do, and that's at about 2 years after surgery. So if you look at the band data over many, many years, only about 25 to 50%, and that's on the high end, of band patients will lose half their excess weight. So we say that the band statistically fails in between 60 and 75% of patients. So that's a very high number. If people are here because they're interested in weight loss, that's not a great number in terms of statistical achievement. Secondly, the band is not a metabolic surgery. So the whole world is now talking about these effects, the ones we've kind of already talked about, these hormonal effects, metabolism effects that happen at the time that we do surgery before weight loss to improve diabetes and important health problems and help people live longer. Well, none of that happens after the band. There's actually never been a study that we've reported in our literature that's ever shown a hormonal metabolic effect of banding. And so that's a disadvantage. And third, and maybe most importantly, the band is a foreign body. It's made of plastic. And that foreign body can cause serious problems for patients. And the likelihood of a serious complication from a band is somewhere between 25 and 50% of surgeries. And that can mean other very complex and important surgeries for patients. And so that number's too high. So that's why we really have, as a community, really tried to dissuade people and steer people away from banding, and it's become less popular. So it's a good segue to the next surgery we're going to talk about, which is the sleeve. And about the time the band started to decrease in popularity in the mid-2000s, the sleeve started to increase in popularity. The sleeve is now the most commonly performed bariatric surgery worldwide. In the US and worldwide, more than 50% of patients now who have surgery have sleeve gastrectomy. So what is this surgery, the sleeve gastrectomy? Well, it's interesting because it's gotten so popular recently, but it's not a new operation. For many, many years, over about a decade, from the late 90s into the 2000s, mid to late 2000s, the sleeve was used as part of that switch surgery that I talked about earlier that we'll go over in more detail, as a way of staging people. What does that mean, staging? It means doing surgeries in steps and taking people who were very high-risk patients and had very high body mass indexes, often 55 and 60 and higher, and doing this procedure to bring the weight of the patient, to bring the BMI of the patient down, to bring their risk for anesthesia down, and then have them have the second part of the operation. And we'll go over some of those second steps. So the sleeve is a very useful surgery, even now, if we want, as a staging surgery for a very high-risk patient. But it's not a new operation. But because it's so popular now and because people went many, many years without hearing of this, people think that we just, have started doing it. So the sleeve's been around for a while, but there's no question it has really grown in popularity in terms of this approach as far as offering it to any patient who's interested in surgery. So what do we do in the sleeve gastrectomy? What we do is we remove about 2/3 of the stomach, and we leave a banana-shaped, comma-shaped, or half-moon reservoir behind. But the sleeve isn't working because we're making the stomach smaller. Okay, that might be, in terms of portion limitation, important for the patient. But we know that there's so much more to what we do now, and the sleeve is the first example of that. When we remove about 2/3 of the stomach, we take away most of the body's appetite hormone. And that hormone is called ghrelin, G-H-R-E-L-I-N. And people, even a lot of people in the community, not just doctors and people in healthcare, like to talk about ghrelin now, the so-called appetite hormone. Now, there's not all the appetite hormone that's removed from the patient, but the majority of it. And so what we have when we do sleeve gastrectomy is an excellent anti-appetite operation. And the drive of the patient to have appetite is significantly reduced. So it's a great, and that's a metabolic effect. That ghrelin is what we mean by one of the gut hormones we were talking about earlier. So it's a great anti-ghrelin, anti-appetite surgery. Now, there's more to the sleeve. The reservoir that's left behind, as a consequence of that stomach being removed, it empties more quickly. Okay? Now, that increased emptying of the stomach, it stimulates the next anatomy from the stomach down, and that's called the small intestine. So when that stomach that we've left, that sleeve, empties more quickly, it stimulates the small gut. That stimulation of the small gut is one of the most important mechanisms for why diabetes starts to improve even before weight loss at the time of surgery. And we call that the hindgut hypothesis of diabetes improvement or remission. And we'll talk about that in a little bit. But that's an important driver of the popularity and growth of the sleeve compared to the band over about the last decade in our field. The sleeve is also a great operation for people who've had a lot of previous surgery. A lot of the people in this room possibly have had a lot of complex abdominal surgery. And in Florida, we serve a lot more senior patients than other parts of the country. And that means that maybe people have had a prior colon operation or complex hernia surgery. And the sleeve can be very useful in those patients because there might not be other options surgically in some of those groups of patients. Now, the sleeve is still very useful as a staging surgery for high-risk patients. That's still a tremendous advantage of the sleeve. And the other thing is that it's perceived by patients to be a much better quality of life operation than some of the other operations we're going to talk about. But there's a lot of things to tell you about all these surgeries, so those are sort of the highlights of the sleeve. Now, what about negatives? Because we talked about the negatives with the band. So the biggest negatives of the sleeve are we have to be cautious in a few patient groups. In people who have something called Barrett's esophagus, that's changes that happen because of gastric acid, and the people who have that diagnosis would know what that means. We have to be a little bit cautious in offering them sleeve gastrectomy. So that's an important thing to be thinking about. So data-wise also, sleeve, even though it's been around a decade now, and we have good short intermediate data, we don't have as much long-term data that we do in gastric bypass and duodenal switch and even in banding. So we've got to remember that as far as quality data in terms of long-term. And last and most important, and I always talk about this with my patients when I see them in the office, if we're seeing someone who wants a sleeve and has that very high body mass index, but they don't want to do other surgery, we do have to mention to them that the sleeve in that scenario could still just be a staging operation, and that there's still a chance that they could require other surgery because they're starting with a very high body mass index. Okay, now it's not 100%. We've had a lot of patients who've had the sleeve with very high body mass indexes and haven't gone on to need or want other surgeries, but I think that's important to mention to patients. Okay, so the next operation we're going to discuss is the laparoscopic Roux and Y gastric bypass. Roux is actually named after a French surgeon, so that's why it's capitalized. So what do we do in this operation? It looks, more complicated. So what we do in gastric bypass is we make a small reservoir out of the stomach, and then we bring up a reconstruction of the small intestine in what's called a Roux and Y, and to make sure that there's no blind limbs or blind channels, when we do this. What's the effect of this operation, and why is this anatomy so important? Well, it's important for really two reasons. In the gastric bypass, as it relates to the metabolic hormonal effect, we have this immediate emptying into the small bowel, like kind of we talked about with the sleeve with the increased gastric emptying and the stimulation of the small bowel. So we have that mechanism working for us in gastric bypass. But we also have another very, very important hormonal mechanism that happens by bypassing all of the old stomach and most of the upper small intestine. And that hypothesis, we talked about hindgut, is called the foregut hypothesis. And what happens is that when food doesn't go through that bypass stomach and upper small gut, is that there are important signals that now aren't contributing to the patient, which can make them more likely to have diabetes and to have poor control of their blood sugar. And that all happens because now the upper gut isn't seeing food. And those important signals and hormones, negative hormones, aren't having a chance to cause problems with our patient. So you have really two important, strong metabolic hormonal mechanisms that are important for diabetes remission after gastric bypass. Now, so that's a wonderful thing about gastric bypass. And there's still many people who consider this to be the quote, gold standard, unquote, operation. But there are some negatives to gastric bypass as well. So it's important in Florida, for us to be talking about that, because we have a lot of patients who have arthritis and are really dependent on certain kinds of medications to get around. So it's important that we tell people that if you have a gastric bypass, we really don't want you taking a class of medications called non-steroidal medicines. Most people know some of the non-steroidals as like Aleve and Naprosyn. So those medicines in combination with this surgery can cause real problems with ulcer. And so we want to make sure that we know who we're offering this surgery to and make sure that people are considering that before they make their choice for surgery. The other important thing about gastric bypass, and the reason why probably the sleeve has gotten so popular, is there's one more long-term effect of gastric bypass that can happen even after people are out of surgery a year or two, and that is a special kind of intestinal blockage called an internal hernia. And that's really one of the strongest disadvantages of gastric bypass. And that's why I think a lot of our medical colleagues like the sleeve, because we don't have to worry too much when a person comes to an emergency room or they're traveling and they show up somewhere that maybe they have this problem. And that problem can be very difficult to find and diagnose. And that's a great advantage of the sleeve over the gastric bypass because there's really no long-term risk in sleeve gastrectomy of that. And the likelihood of that happening in a gastric bypass patient, depending on the article you read, can be up to about 4 in 100 or 4% of patients. So it's not an insignificant number. And those are probably the two greatest drawbacks of gastric bypass. Now, one thing that's important for me to mention as we go on to our next surgery, which is the duodenal switch surgery, is that in all these operations, you have to take vitamins and supplements, and we have important nutritional counseling that happens as part of what we do to get people ready for surgery. But I think that people always have a perception that you only really need to supplement as we talk about gastric bypass and duodenal switch surgeries. And you don't have to do that if you have a sleeve or even a band. And we know that supplementation is important no matter what operation people have. It's just that as we've gone through our progression of talking about these surgeries, it becomes more important. So it's more important for the duodenal switch person, it's more important for the gastric bypass person, it's important for the sleeve patient, but it's not as critical. So the next operation and last operation we're going to talk about is the duodenal switch. And what do we do in this surgery? Well, in this operation, what we do is we do a reservoir, just like we do in gastric bypass. In gastric bypass, that reservoir is the shape of a thumb. In the duodenal switch, that reservoir is the sleeve. Remember I told you that's where the sleeve came from. It came from the duodenal switch. The duodenal switch was done for many, many years, and the sleeve was a staging mechanism for people who couldn't tolerate a whole duodenal switch operation. So you have the sleeve reservoir, and then we also have a bypass that goes underneath that reservoir. Now, the difference between this type of bypass and the Roux-en-Y gastric bypass that we just talked about is there's a lot longer limbs in the duodenal switch and a lot shorter channel. And what does that mean? What it means is that when the food side of things mixes with the digestive enzyme side, those two sides are much longer than a gastric bypass. And what that means is when we bring those two things back together, the amount of intestine that's left for people to be able to absorb their nutrients and what they need to live on is much shorter. So as a result, people with a duodenal switch will have what we call more malabsorption. So there's a tendency for more things to go through more quickly. And honestly, that's probably the reason why the duodenal switch has really never become a very popular operation. To give you a perspective on this operation, it's done in less than 0.5% of center of excellence surgery centers in the United States. So it's just not very commonly performed. And the reason has a lot to do with that malabsorption, because with that malabsorption comes a reduced quality of life. People have more frequent bowel function, and if they live and work in an environment where it's important for them to be around people, they can have malodorous gas, and that can be very debilitating to people. And I think it's probably the reduced quality of life that really has driven people away from duodenal switch over the years. But it is an excellent metabolic surgery, and the effects that we went over for gastric bypass that happen hormonally and metabolically are certainly happening in people with duodenal switch, and maybe even more powerfully so. But it's just not ever really caught on in the US or even really worldwide. So that's an overview of the 4 operations, and we're going to hear more about them shortly. So the next part of the talk has to do with the safety of bariatric surgery. You know, I've been in this field a long time. This is my 16th year operating in bariatric surgery. And it really wasn't that long ago that people considered that what we do was drastic or even dangerous. So this part of the talk is very important because we talk a lot about safety. And I think it's very important for everyone here that when you go out and talk to other people, that you also do a good job of communicating to people that bariatric surgery is actually really quite safe. So this study, which is called LABS, the LABS study, is a study of 5,000 patients in academic centers in the United States that have been studied over a long time. And this was a very important study when it was published in the New England Journal in 2009, because again, people still had this perception that bariatric surgery was drastic and very, very dangerous. But this study was very good because it showed that the risk to one's life with surgery was about 3 in 1,000, which is in the same order of many of the other operations that most of us have heard of. This was, which is called BOLD, which is the first study of one of our centers of excellence, which was also a very important study at the time that it came out, to again look at the risk to one's life within 30 days of surgery. And according to BOLD, which is in Center of Excellence hospitals, the risk to one's life is under 1 in 1,000 at 30 days from surgery. And in fact, at 1 year, the risk to one's life is just over 1 per 1,000. And this was a very important study as well. This study I really like a lot because most of the people here and most of the people that you're going to go out and talk to have heard of other surgeries to compare bariatric surgery to. So this was a study done that compared bariatric surgery to other well-known and performed other general surgeries. So bariatric surgery in this study was compared to anti-heartburn surgery, appendectomy, gallbladder, colon removal, hernia done on the front of the abdominal wall, and removal of the rectum. So in this study, it shows that bariatric surgery is actually the second safest operation. Only appendectomy has less complications and less risk to one's life. Bariatric surgery, according to this study, is actually safer than gallbladder surgery. And I always ask people at this point in the seminar, anybody that walked in the room that would think, before they walked in here, that bariatric surgery would be safer than gallbladder surgery? And we never have anybody who raises their hands. Because we haven't had a historical, education that bariatric surgery could be as safe or safer than gallbladder surgery. So I like this study a lot. It's a nice comparison of some of the operations we've been talking about to each other. And the study comes from Michigan. And in terms of our data, Michigan is a very robust and quality state for bariatric surgery because all the programs that perform bariatric surgery in Michigan are all part of this database. So we really like and pay attention to the data that comes from Michigan. In fact, when we redesigned our Center of Excellence, that MISQUIP, it was designed after the Michigan Collaborative. So this study from Michigan compared sleeve patients, gastric bypass patients, and band patients. 3,000 patients in each group. So, how do they compare to each other? Well, in terms of the risk of serious complication, and this is at 30 days after surgery, the blue being gastric bypass, the green being sleeve gastrectomy, and the olive color being the band, the operations compare very well with each other. Sleeve and gastric bypass have a cumulative likelihood of causing a serious complication within 30 days of about 2.5%, which is quite low compared to a lot of the other operations that we kind of talked about earlier. It is true that band patients have less serious complication in the 30 days, but we'll talk about what happens in the more long term later on. The risk to one's life for all these operations are between 1 in 1,000 or less. Now, what about some of the likelihood of more serious complications? And what are these serious complications? We kind of alluded to it a few times now in the talk. So really when we're talking about things that people should be concerned with, other than risk to one's life, which we've discussed, we talk about this idea of leak, intestinal blockage, infection, bleeding that would require a blood transfusion, and blood clot events. Okay? So those are kind of the things that when we talk to other docs and patients talk amongst themselves that they're really alluding to when they say, well, that surgery has a lot of complications. What they're talking about is the risk of serious complication. So to give you a sense of what that looks like, the leak rate in a gastric bypass is about 0.5%. And in the sleeve patient, it's about 1%. In terms of serious intestinal obstruction, about 3 in 100 with the gastric bypass, and about 1 in 100 with the sleeve. In terms of the risk of bleeding, requiring blood transfusion, about 1 in 100 with a sleeve and about 2 in 100 with a gastric bypass. And in terms of blood clot events, they're both very similar, 1 in about 200 as far as the likelihood of that happening. But you do see in this slide that the band patient has a much lower risk in terms of short-term complication, and that is true. Now, what about some of the other things here on this slide? LOS, what does that mean? Length of stay. So the length of stay in a gastric bypass and a sleeve is about 2 days, and they're similar. Whereas a band patient generally is going home the same day or just after one overnight. But you see that the likelihood of other serious things that can happen after surgery, like reoperations, readmissions to the hospitals, transfer to other facilities, and visits to the emergency room, are all quite low. So how do these operations compare to each other as far as weight loss? Okay, so let's look at that. Again, same color combination throughout these slides. The gastric bypass patient at 1 year will lose about 70% of their excess weight. The sleeve patient will lose about 60% of one's excess weight. You see that throughout the time, 1, 2, and 3 years, that the band patient never gets to that key 50% number. When we get out to 3 years, we see that a gastric bypass patient maintains their weight loss, excess weight loss, of about 67%. The sleeve patient's in the 50% range, and the band patient, again, has not yet attained that 50% mark. Now, what about other health-related problems? Because this is ultimately why we do these surgeries. To help people have a better quality of life, but most importantly, to help them live longer and eradicate their medical problems or make them much better. So this same study in Michigan looked at what we call remission. That's that the disease is effectively gone. We used to say cure not that long ago, but our medical colleagues get upset. So now we use this word remission. So what is the likelihood of these problems being in remission at a year after surgery by the procedure that we've done? So this study looked at diabetes, not requiring insulin, and requiring insulin. So if you're a diabetic not requiring insulin, the likelihood in a year that you have remission of diabetes with a gastric bypass is about 80%. If you have a sleeve, it's about 66%. If you're insulin requiring, your likelihood of remission is 64% with a gastric bypass, 42% with a sleeve gastrectomy. What about sleep apnea? 66% remission with a gastric bypass, 57% remission with a sleeve. And then we see some of these other problems like lipid problems and high blood pressure. But again, you pretty well, like in the weight loss curves, you see that basically gastric bypass patients tend to do better than the sleeve patient that tends to do better than the band. Okay, so next we're going to talk about another important database and publication that I like, which is a report from the American College of Surgeons. And they also looked at about 30,000 patients who had bariatric surgery in a center of excellence. In this study, they showed a mortality number similar to what we've been talking about 1 in 1,000 at 30 days. But this study's nice because it looked at not just percentage of excess weight loss, but it looked at the reduction in the number of BMI. And the reason this number is important to know is because a lot of our patients, especially here in Florida, have to have joint replacements who have arthritis. And we like to tell the joint surgeons that you should refer the patients for bariatric surgery first and then perform the orthopedic joint replacement. In even their society, the American Association of Orthopedic Surgeons, the AOS, is recommending now that they take caution for high BMI patients. So they want to know, our orthopedic surgeons want to know, if they send a patient to us, how many BMI points will they reduce? Because they really want that number under 40 for joint replacement. So this study showed that for a gastric bypass, patients lose about 15 BMI points at a year. For a sleeve patient, they lose about 11 or 12 points, and for a band patient, about 5 to 7 points. Now, this is how comorbidities behaved in this study. They looked at all diabetics together, those that required insulin and those that didn't require insulin. And the same color coding applies. So you see here that gastric bypass remission of diabetes was 83% versus 55% with the sleeve. For high blood pressure, about 80% remission with a gastric bypass, about 70% remission with a sleeve. For sleep apnea, remission was very good in both groups, about 70 and 60% gastric bypass and sleeve. And then you also see for lipid problems and for reflux. But again, it's that same shape of the curve that we've shown you for weight loss and in the other study, the Michigan study, in terms of how the surgeries go as far as improvement. In terms of complications, they are almost mirror images of the data I showed you from Michigan. Okay, so we get to probably the most important part of the talk, and that is we've seen how people can have surgery, can have improvements in their quality of life, how their diseases can get better, many of them become significantly improved or even eradicated. But this is the most important thing, the ability to extend life and save lives. And that's the most exciting thing that I get to do as a bariatric surgeon. So there's these studies that have been done on life expectancy for people who've had surgery. And the way these studies are designed is we look at people who've had surgery and have needed it, compared to the people who've not had surgery but have needed it. And we compare those two groups. So this is a study done in Canada. They looked at the 5-year death rate in people who had surgery compared to medically managed patients who didn't have surgery, who needed it. And they looked at the differences. In the surgical group, the rate of death at 5 years was just over 0.5%. In the medical group, the rate of death was over 6%. Surgery led to a relative risk reduction of 90%. This is probably the most popular study reference now in bariatric surgery. This is a study that looked at gastric bypass patients in Utah who had surgery, 8,000 of them, to 8,000 people who need surgery who decided not to have it. The follow-up was 7 years. The overall decrease in mortality, death, in the people who had surgery compared to those people who didn't was 40%. We call that all-cause mortality benefit. And you'll see that term more and more, even in newspapers. Now, if you want to look at specific disease states, the data is even more impressive. When we looked at diabetics who had surgery and compared to the diabetics who didn't have surgery, the mortality benefit was 92%. For people who had any history of heart disease, the mortality benefit, 56%. For people with any history of cancer, the mortality benefit, 60%. So these are what we call awesome numbers. So what about in other studies? Well, this was a study from Sweden. It's called the Swedish Obese Subject Study. And this study has been going on, it's a comparative study, for more than 3 decades in Sweden. And in their 11-year data, they saw an overall almost 30% reduction in that same all-cause mortality benefit. This is a study from South Carolina that looked at reductions in mortality specifically for just those diabetics. They found a 67% reduction in mortality among the diabetics who had surgery compared to the diabetics who were severely obese who did not have surgery. So when I summarize for other practitioners and I talk to people and they ask me about mortality benefit, especially for diabetes, I tell them that the range of benefit is between 67 and 92%. And that's just a very, very impressive number when you're talking to people about lives saved. And the last part of the talk is about the Diabetes Surgery Summit. Now, this is called DSS2. It's the second Diabetes Surgery Summit. It has been an effort over about a decade of the entire international community of people caring for diabetics. These are not just surgeons. These are diabetologists, endocrinologists, family doctors, cardiologists, internists from all over the world who have recognized that we have a global health crisis as it relates to diabetes. And this is the third effort in about 10 years to try to get the medical community to understand the role and place for surgery in the care of the patient with type 2 diabetes. Because right now, as we speak, there is little in the way of guidance or direction or mention of surgery in the use and treatment of type 2 diabetes. So the conclusions of this summit, the most important ones, were that surgery should be recommended for diabetes this idea of diabetes surgery for a patient who has a body mass index over 35, regardless. And that we should even consider surgery in patients who have diabetes who have the lower BMI, the class 1 BMI, if they're not making their important medical targets with their doctors. And the idea that we should think about this as a new treatment specifically dedicated to diabetes, not only after the patients have been on other treatments and have failed them and have serious other problems, like heart disease, like stroke, like limb loss, amputations, like dialysis, like blindness. We want to get to our patients sooner before they develop these problems. So there have been 11 what we call randomized controlled trials. These are the highest level of medical evidence in our journals. They're called level 1 evidence papers that have compared surgery for diabetes to medical and lifestyle management. And in all of these publications, surgery has been shown to be superior to medical lifestyle management. So let's just go over a few of these that have gotten a lot of attention, especially recently. We'll talk about the second one on the list, which is Dr. Shower's Stampede investigations. These were from the Cleveland Clinic in Cleveland, Ohio, and they're published in the New England Journal, year 2 and year 3 results. In the year 3 results, according to the Stampede trial, if you compare people who have gastric bypass, sleeve gastrectomy, and medical treatment, the remission rate is highest for gastric bypass, then sleeve gastrectomy, and we see a 0% remission with medical lifestyle management compared to 20 and 35% with sleeve and gastric bypass. Another important study that's gotten a lot of attention, this study from Monroe and Rubino. This looked at gastric bypass, duodenal switch, and medical patients. And this was out 5 years. 68% remission in the switch patient, 42% remission in the gastric bypass patient, and again, 0% remission with medical treatment. And lastly, this study from Saeed Akramidin, University of Minnesota, that looked at composite scores of other things that are important to diabetics, like their lipid control, their blood pressure control, and their diabetic control. So they made a composite score of those three and compared gastric bypass patients to control patients in 2 years. 45% of the surgery patients met the composite goal with surgery, and only 9%, less than 10% of the patients met it with medications. So in summary, surgery has clearly been demonstrated to be superior to medical lifestyle management for type 2 diabetics. And it is imperative and critical for all people who interact with patients who are diabetic from all walks of life and all specialties of medicine that surgery has a place in the discussion with patients. And we want to make sure that you know, and all our patients know, that surgery should be offered or considered for a patient with diabetes. These three quotes really stand out at me as a result of DSS-2. There has been an inexorable, meaning unrelenting, an unsustainable increase in global health expenditures attributed to diabetes. The next one, type 2 diabetes, along with obesity, may yet be the greatest chronic epidemic in the history of human existence. And lastly, we have had a meteoric rise, greater than twofold increase from 151 million people who had diabetes in 2000 to the current estimate of over 400 million people worldwide. Why is it important? Why am I spending so much time on this? Because you are going to be an important voice leaving here to go out into the world and help people understand what a big problem diabetes is and how surgery can be useful in treating diabetes. In the United States, there are currently 30 million type 2 diabetics. Currently, diabetes occupies 1 in 3 Medicare dollars in terms of expenditure. In the US, it's 1 in 5 dollars of healthcare dollars now spent in diabetes. The costs of diabetes in just the last 5 years have increased 41%. We cannot keep up with the cost attributable to diabetes. In Florida, the problem is even more critical. Florida is now second only to California in terms of expenditures with regard to diabetes care at $19 billion a year. I have felt so strongly about the place of surgery in the care of the type 2 diabetic that I am now a member, and I am the chair-elect of the Diabetes Advisory Council for the state of Florida. And all of the people on that council have been appointed by the governor. And we are very concerned with the rate of growth in the expenditures, as well as the number of people who are being afflicted by diabetes, and also the lack of patients having complete access to all available treatment options, prevention and education as far as diabetes is concerned in Florida. The cost savings of surgery are very significant. The last international effort to educate the public on the diabetes epidemic was this, the International Diabetes Federation position statement on diabetes. The estimate at that time was the US cost per individual is between $170,000 and $305,000. Now you can do the math. We talked about there being 30 million people in the US, and you look at the cost per individual, and it doesn't take long to start talking about a problem that's not just in the billions, but in the trillions, and especially with the rate of projected growth in the number of diabetics in the next 5 and even 10 and 15 years. The cost savings with surgery for direct costs and total costs per 1,000 patients over 10 years is between 2.7 million and 5.4 million, respectively. When Medicare makes decisions to cover interventions, they use this terminology quality adjusted life year. The cost of diabetes care and care for lipid lowering agents and high blood pressure is about $41,000 to $51,000 per quality adjusted life year. The ratios for surgery, 7 to 12,000 for newly diagnosed and established diabetes. It's essentially making the argument that surgery is not just cost savings, but cost dominant. It doesn't just pay for itself, it pays for other things as well. So I really do appreciate your attention to those important slides that we discussed. And we get to this point in the talk because invariably the question always becomes, well, Dr. Shavli, you've been involved in bariatric surgery a long time. How many surgeries have you done? So I always like to give people a sense of what I've done and how the cases have distributed themselves over the years. So I've done a little over 1,500 operations in my career, over my 16-year career in bariatric surgery. We've done about 900 gastric bypasses, about 300 sleeve gastrectomies, about 200 gastric bands, and about 300 we call revision bariatric surgeries. So what do we offer? You've heard this about all the surgeries, so what do I offer? We offer patients the laparoscopic gastric band, the sleeve gastrectomy, the gastric bypass, and revision bariatric surgery. I want to thank everybody for coming today and really tell you how much we appreciate you being here. I want to let you know that we are more than happy and welcome you all to the office for a doctor's appointment. Please feel free to call the phone number and we'll get everybody usually in within about 10 days or less of calling the office for an appointment. We don't like our patients to wait to see us. And so we're very excited to meet you in the office setting if you desire. I also want to let you know that we have a very dynamic and interactive website. We have our diets on there. We have a lot of great multimedia educational videos and lots of other great educational resources. So look at the website, and that can also help you very much with what you've learned here today and kind of complete the picture. So we'd be happy to see you in the office. We welcome you to contact us for any questions, additional questions you might have. If anything is at all confusing that you viewed or you sat through, then please don't hesitate to reach out to us, and we're happy to talk to you anytime. And I really do thank you, and thanks for being here.